Welcome to this video course on psychiatry and neurology. If you have a basic science background, this guide will help you understand these two medical specialties, how they differ, and their underlying anatomy and physiology. This is our course roadmap. We will begin by defining the two fields and exploring their history, then dive into the foundations of the nervous system, brain anatomy, and physiology, before examining diagnostic tools, common disorders, and finally, a synthesis of key takeaways. Why learn this distinction? First, these are two separate medical specialties, and understanding the difference helps patients navigate their care. Second, confusion between the two creates stigma. Finally, many conditions, such as dementia or traumatic brain injury, sit at the intersection of both fields. Section 1. Psychiatry versus neurology. We will examine these two medical specialties that grew from the same root but eventually diverged in their clinical methods. What is psychiatry? It is a medical specialty focused on mental illness. Psychiatrists are physicians who diagnose and treat disorders of mood, thought, and behavior. Diagnosis relies on clinical interviews and observed behavior rather than lab tests, and treatment often combines biological medications with psychotherapy. In contrast, neurology is a medical specialty focused on the nervous system as an organ system. Neurologists diagnose and treat physical disorders of the brain, spinal cord, nerves, and muscles. Their diagnosis involves physical exams and objective testing, and treatments target underlying structural or electrical problems. The two fields share a long history. In the 1800s, they emerged from the same studies of nervous system diseases. Over time, neurology aligned with anatomy and localization, while psychiatry developed different models. Today, they remain distinct, but bridge together in subspecialties like neuropsychiatry. Each field approaches a patient with a different core question. Neurology asks, where is the lesion, and looks for damaged tissue or objective abnormalities. Psychiatry asks, what is the pattern of experience and behavior, and looks at how a patient's mood or thoughts deviate from their baseline. Their diagnostic processes differ as well. Neurologists use physical exams and tools like MRIs or EEGs to localize a structural or electrical cause. Psychiatrists use mental status exams and symptom criteria over time, often using labs and imaging primarily to rule out other medical causes. This table summarizes the tools of the trade. While neurology relies on physical exams and structural imaging to localize disease, psychiatry utilizes mental status exams and standardized diagnostic criteria to understand behavioral patterns, with both fields employing distinct medication classes. Neuropsychiatry is the overlap zone. Brain disease can manifest as psychiatric symptoms, such as depression caused by a stroke. Conversely, psychiatric illnesses have biological correlates. Consequently, some complex conditions require both specialties to work together for effective management. In summary, neurology focuses on the brain and nervous system as physical structures, while psychiatry focuses on brain function as it produces mind and behavior. Both require rigorous residency training and work to identify either specific lesions or patterns of symptoms. Section 2. Nervous System Foundations. We will now explore the biological building blocks that both specialties ultimately study. The nervous system is divided into the central and peripheral systems. The central nervous system, or CNS, includes the brain and spinal cord, which act as our command center. The peripheral system, or PNS, connects the CNS to the rest of the body through cranial, spinal, and autonomic nerves. This diagram illustrates the hierarchical divisions of the nervous system, from the CNS containing the brain and spinal cord to the PNS, which includes the somatic system for voluntary control and the autonomic system for involuntary processes like fight or flight or rest and digest responses. At the cellular level, the neuron is the basic signaling unit of the nervous system. Key components include dendrites, which receive incoming signals, the cell body or soma, which integrates them, and the axon, which carries the signal away, often protected by a myelin sheath that accelerates conduction. Finally, axon terminals release neurotransmitters to signal the next cell. Neurons also serve different functional roles. Sensory or afferent neurons carry signals from the body to the CNS. Motor or efferent neurons carry commands from the CNS to the muscles. Interneurons, which make up the vast majority of neurons in the brain, connect other neurons to each other within the central nervous system. While neurons carry the signals, glial cells are the essential supporting cast. Astrocytes regulate the chemical environment and blood-brain barrier. Oligodendrocytes and Schwann cells produce myelin to insulate axons. Microglia act as the brain's resident immune system, clearing debris and responding to injury, with increasing research linking them to psychiatric and neurodegenerative diseases. Communication happens at the synapse. An action potential triggers neurotransmitter release from the presynaptic neuron into the synaptic cleft. These molecules diffuse across the gap and bind to receptors on the postsynaptic neuron, which can excite or inhibit it. Leftover neurotransmitter is then either broken down or reabsorbed, which is a major target for many psychiatric medications. Several major neurotransmitters drive brain function. Dopamine regulates reward and motor control. Serotonin manages mood and sleep. Glutamate is the primary excitatory signal, while GABA is the main inhibitor. Norepinephrine is involved in arousal and stress, and acetylcholine is critical for muscle activation and memory, with all of these serving as vital points of clinical relevance. Section 3. Brain anatomy. We will now move from the cellular level to examine the architecture of the whole organ and its major functional regions. The brain consists of 4 major divisions. The cerebrum is the largest part, responsible for higher cognition and movement. The diencephalon, including the thalamus and hypothalamus, acts as a sensory and hormonal relay. The brainstem controls basic survival functions like breathing, and the cerebellum is dedicated to coordinating balance and fine-tuning movement. The cerebrum is divided into 2 hemispheres connected by the corpus callosum, allowing constant information sharing. They demonstrate contralateral control, where each side governs the opposite side of the body. While left brain or right brain ideas are often oversimplified, distinct functional biases exist, such as language dominance in the left and spatial attention in the right. The cerebrum is further divided into 4 lobes. The frontal lobe governs planning and personality. The parietal lobe manages touch and spatial sense. The temporal lobe handles hearing and language, and the occipital lobe is dedicated to vision. Note that these regional boundaries are functional and gradual, rather than sharp physical lines. The frontal lobe is our executive center. It handles high-level functions like planning, decision-making, and impulse control, primarily in the prefrontal cortex. Behind that, the motor cortex initiates voluntary movement. Damage to this area is a significant intersection for psychiatry, as it can profoundly alter a patient's personality and social behavior. The parietal lobe specializes in sensory integration. It maps the body in space and processes touch, temperature, and pain from the opposite side. By combining vision, touch, and proprioception, it allows us to interact with the world. Clinical issues here can result in unique phenomena, like neglecting one side of the sensory world. The temporal lobe is essential for hearing, memory, and emotional meaning. It hosts the auditory cortex and language centers. Crucially, it houses the hippocampus for memory formation and the amygdala, which processes fear and emotional salience, making this lobe a vital hub in both neurology and psychiatry. The occipital lobe is the brain's visual processing center. It receives raw input relayed from the eyes to the primary visual cortex, while surrounding areas interpret color, motion, and form. In a clinical setting, an occipital lobe stroke is often identified by visual field loss, providing a key localizing clue for neurologists. The limbic system is perhaps the most important anatomical bridge for neuropsychiatry. It includes the amygdala for fear, the hippocampus for memory, the cingulate cortex for attention, and the hypothalamus for autonomic responses. Because these structures regulate our emotional state, they are the primary sites where neurological and psychiatric disorders often converge. Finally, the basal ganglia are a collection of deep structures that fine-tune voluntary movement and govern motivation. By creating feedback loops between the thalamus and the cortex, they help initiate desired actions and suppress unwanted ones. Dysfunction here is central to Parkinson's disease, as well as psychiatric conditions like OCD and addiction. The diencephalon includes the thalamus and the hypothalamus. The thalamus acts as the brain's sensory relay station, directing almost all sensory input to the cortex. The hypothalamus is the master regulator, controlling homeostasis, everything from hunger and thirst to temperature and hormonal output through the pituitary gland. The brainstem connects the brain to the spinal cord and is composed of the midbrain, pons, and medulla. It handles essential life-sustaining functions like heart rate, breathing, and sleep-wake cycles. Because these vital centers are packed into such a small area, even minor strokes here can be life-threatening. The cerebellum, located beneath the occipital lobe, is the brain's coordination center. While it represents a small portion of the total brain volume, it contains roughly half of our neurons. It fine-tunes movement, maintains balance, and coordinates posture. Injury here typically results in ataxia, causing unsteady, uncoordinated movement. Protective structures include the meninges and the ventricular system. 3 layers of meninges surround the brain, while cerebrospinal fluid, produced by the ventricles, cushions the brain and removes waste products. Blockages in this flow lead to hydrocephalus, while infections of the meninges result in meningitis. Section 4. The spinal cord and peripheral nervous system. We will now examine how the brain communicates with the rest of the body through the spinal cord and peripheral networks. The spinal cord features a central butterfly of gray matter, housing nerve cell bodies surrounded by white matter tracts. The dorsal horns receive sensory information, while the ventral horns send out motor commands. White matter tracts are the superhighways for signals traveling to and from the brain. Tracts are divided into ascending sensory paths and descending motor paths. Most of these fibers decussate or cross over in the medulla. This explains why a stroke in the left side of the brain typically causes physical symptoms on the right side of the body. There are 31 pairs of spinal nerves that emerge from the cord, each carrying both sensory and motor fibers. Each nerve supplies a specific strip of skin, known as a dermatome. Clinicians use these dermatome maps to pinpoint exactly where a spinal injury or disc herniation has occurred. Cranial nerves are the 12 pairs of nerves that emerge directly from the brain and brainstem. They provide sensory and motor innervation primarily to the head and neck, with the exception of the vagus nerve, which extends its influence deep into the thoracic and abdominal organs. The autonomic nervous system balances 2 opposing systems, the sympathetic or fight or flight response, and the parasympathetic or rest and digest system. While they operate continuously, imbalances in these systems are critical in understanding psychiatric conditions like anxiety disorders, which often feature sustained sympathetic activation. Section 5. Physiology. We will now move beyond anatomy to understand the electrochemical processes that allow nervous tissue to generate and transmit signals. The action potential is the fundamental unit of neuronal signaling. At rest, the neuron is polarized at -70 millivolts. When a threshold stimulus is met, sodium ions rush into the cell, causing depolarization. After the signal passes, the cell repolarizes, resetting the membrane for the next pulse. Synaptic transmission begins when an action potential reaches the axon terminal. This triggers calcium channels to open, prompting neurotransmitter vesicles to fuse with the membrane. The chemicals cross the cleft, bind to receptors on the next cell, and finally the signal is terminated through reuptake or enzymatic breakdown. Neurotransmitter systems are the common language shared by psychiatry and neurology. From dopamine-related movement disorders and addiction to serotonin-driven mood regulation, these chemicals bridge structural brain function and clinical psychiatric states. Finally, we must consider neuroplasticity. The brain is not static. Synapses strengthen or weaken based on use, a process that underpins all learning and memory. Furthermore, neurogenesis, the creation of new neurons, continues in the hippocampus throughout life, offering hope for recovery and the potential mechanism for many therapeutic interventions.